Good morning to everyone. I go to present a case. It's very interesting case to see something different in trauma. Okay, let's go. I have present a 75-year-old man who was hit by a car. He arrived at the emergency room with a clear airway, respiratory rate 115 EPM, saturations 98%, trachea centered without jugular stase, catheter of 2 liters by minute, breath, vesicular movement present, systolic pressures like 220 by 127 millimeters of mercury. Cardiac rate is 67 BPM. Introduce saline and disability Glasgow Coma score 15. Pupil isochoric and photovoyagent. Small contusion on the left shoulder. What to do with this patient, Valeria?
Thank you, Dr. Collet. Dr. Fraga, your comments, please.
So you have an elderly, he was hit by a car, he is stable, he has systolic hypertension, the cardiac rate is low, the rate. Does this patient use medication, Dr. Collet?
What you ask, Gustavo?
If he takes medication every day?
No, no.
And does he has hypertension or cardiac problems, or does he use anticoagulation?
No medication.
No medication. Yeah, the patient is stable. He was hit by a car. I think you need to follow the ATLS protocol, have a chest and pelvis X-ray at the emergency department, and a fast ultrasound, do the EFAST at the emergency department, and probably you need to talk with the pre-hospital team about how was the trauma, the event. If there is a high energy, usually there is a high energy when a person is hit by a car, probably we have to do a CT scan, whole body CT scan.
Thank you, Dr. Fraga.
Thank you.
Dr. Antrak, your comments?
Yes, I agree with everything that Dr. Fraga said. And in this case, pretty much you have the primary survey already done on this slide. And an elderly man with a high blood pressure, you know, we don't really have a history. He might, if he has a history of hypertension, that's probably even high for even for somebody in the 70s. And the problem is you can't let the blood pressure fall too rapidly, either by treating it medically or if there's a bleeding, by allowing by not getting control of the blood loss and allowing the blood pressure to fall too quickly, because that can precipitate a stroke. So in this case, I think we're now at the level of the secondary survey. He needs a very, very careful exam history, including what happened, did he lose consciousness, very careful exam, including the ultrasound would be part of the exam. And then in this case, because certainly, you know, not seeing him, I would agree with getting a CT, head, neck, chest, and abdomen and pelvis.
Thank you, Dr. Antrak. Dr. Kasim, your comments, please.
Good morning. I agree with the previous speakers. And they have outlined what they would be doing. And the question here is this the undiagnosed hypertension in a 70-plus-year-old man who was hit by a car, or is it something more sinister? So he appears to be very stable, and I would slow down the IV. He doesn't need any IV fluid. I think I would just keep it open, keep the line open. But I think you should do a thorough physical examination, including a thorough vascular examination of both the carotid, looking for any bruits in the neck and also in the renal artery area. Quite often, the attending physicians miss that, and I would recommend that you put your stethoscope over the renal artery and to see if there is any bruits that you are seeing for an inadvertent injury to the renal vessel in the trauma the patient sustained, giving rise to systolic hypertension. Other than that, again, he's very stable, and it doesn't appear that he is bleeding. And I would follow the ATLS protocol. And if you want to send him for imaging, I think it is quite safe for the patient to go for imaging at this moment. Thank you.
Thank you, Dr. Kasim. Dr. Ochman, any comments?
I would probably would not be doing anything because this patient, by our own protocols, he will be managed by DED, and they will call us if we are needed. He met only one criteria, pedestrian hit by a car. So those patients we get a lot, and they are managed by DED, and they call us. If by any chance it happened that this is a full trauma activation, will be chest X-ray and pelvic X-ray. I don't think I will do them fast, although it can be done, because if he's not hemodynamically unstable, maybe to look for pneumothoraces, but we do the chest X-ray so fast that we usually don't look for that unless we have any questions. And after that, CT scan. I don't see, there is nothing unusual in this patient. So that's all I can say. I imagine there will be something because Dr. Collet is presenting, but at this time it wouldn't raise an eyebrow, this presentation. Thank you.
Thank you, Dr. Hochman. Dr. Supa, I'm not sure if you had a chance to hear the case.
I agree with all the comments to carefully examine the patient for obvious trauma and to get the CT scan when the patient is stable. I would like to add a chest X-ray and a pelvic film to screen for chest injury and pelvic fracture. Thank you very much.
Thank you, Doctor. Dr. Nedelkovic, do you want to add any comments?
Good morning. I jumped in a little late, but I think I got the idea of what's going on here. I agree with all the comments. If this patient has pain being hit by a car, I mean, I would, try to give something for pain, see if that's going to help the blood pressure. I just had somebody recently with a urinary retention and a bladder distension on the fast. And if I see that, then probably putting a Foley may help with the blood pressure. But that's all I have for now. Thank you.
Thank you, Doctor. Doctor, anyone else? Any comment? No. And Dr. Collet, we go back to you.
Okay, let's go to what's happened. So this patient, in this hospital, we don't have ultrasound in the emergency room, and the X-ray and the CT may be probably, the patient is very stable, although the hypertension, but it's stable. So we make a CT. The cranial CT, the head CT is normal, the neck is normal, so you can see the abdomen and the chest. Here you can see the abdominal and the chest. There is no pneumo, no injuries of vessels, only some signs of the age of the patient. And then you can go to the abdomen. In the abdomen, you can see a large pneumoperitoneum. And you can see here pneumoperitoneum, and you can confirm using the lung. You can see no pneumothorax. You can see here, and then you can see here. You can see now a pneumoperitoneum. So at this moment, you have a stable patient. He has no abdominal pain, and you have a pneumoperitoneum. What to do with these patients now?
Dr. Kasim, would you like to start with the comments?
Well, again, you go back and do a physical examination. And after having this, seen the pneumoperitoneum, that you have to ask for yourself, is this a viscous injury or is it something else? So on physical examination, you will look for peritoneal signs, tenderness, localized tenderness anywhere. And sometimes older patients like this, they have a condition called pneumocystosis intestinale. And in blunt trauma to the abdomen in a car accident like that, some of these cyst-like structures in the colon specifically, they rupture and they can give rise to pneumoperitoneum, but the patient will be totally asymptomatic. I see that the patient has a big bladder as well, and I think Dr. Somebody mentioned that you should put a Foley catheter in. I think it'll be a good idea as well to put a Foley catheter in to decompress the bladder. And then you look at the laboratory values to see if he's got any elevated white counts, band cells, etc. So pneumoperitoneum by itself, without clinical evidence of peritonitis, is a benign condition. And like I said, that you can have pneumocystosis intestinale in an elderly man. But Dr. Collet obviously will not show us this case unless he's got, he's not going to let the cat out of the bag. And I think we'll find out that this is a strange case. And I'm looking forward to what he's going to teach us. Thank you.
Thank you, Dr. Kasim. Dr. Supa, would you like to make a comment?
Usually with this finding, I think is a good indication for exploratory laparotomy. But in this patient, he remains stable. He has no peritoneal sign, and he has unexplained free air in the abdomen. I think option number one is to decompress the stomach, because he has this tended stomach and duodenum, and rest his bowel and do the serial clinical examination. And if anything changed, we can perform laparotomy later. The second option is if you want to do something less than laparotomy in this gentleman, I think putting in the laparoscopy is an option for this patient. Thank you.
Thank you, Dr. Supa. Dr. Ahman, would you like to make a comment?
So benign pneumoperitoneum in a man is unusual. Woman is more frequent, but my first suspicion will be this is an unrecognized pneumothorax that somehow have leaked into the abdomen instead of causing a problem in the chest, maybe because of additions of the lung. Particularly, he has no symptoms. The other possibility, 70 years old, I don't know what his mental status, but sometimes patients with dementia or other type of neurologic conditions, they might not have pain for when they have peritonitis, but I think it's rare. There are a few things that surprise me. One is the stomach is huge, huge. And so it suggests to me that this guy might have a pyloric obstruction. And now that you're going over the chest, go slowly. I'm not sure if you can show the arch of the aorta, because it looked for a second that he has a flap in the arch of the aorta that suggests maybe a dissection. That stomach is massive. And if it's a stomach, I think it's a stomach. The NG tube is, I really cannot see where the NG tube goes there. There is a tube if you go a little bit lower. So it's kind of very weird. I need to see the CAT scan in different views. Just to rule out that flap in the arch of the aorta and exactly what is causing this in the stomach. If it is the stomach, I think it's the stomach. I imagine that this has something to do with the whole process, but that's all I can say so far. If the patient has no pain, I will kind of like, no, there's no NG tube. I saw an NG tube. I will just wait and see.
Thank you, Dr. Hochman. Dr. Antrak, your comments?
Yeah, so at first I thought that was, the stomach is large, but I thought inferiorly that was the transverse colon, but it might actually, I mean, it's hard to tell. But it also looks like there is some thickened, loops of bowel with thickened wall, and around the liver, looks like there's some fluid around the liver. So, but in this case, I'd be reluctant to do a laparotomy or laparoscopy to put this patient under general anesthesia without getting the blood pressure a little bit more settled down. And I agree with the Foley catheter, and then seeing what happens to his blood pressure. And then if he remains awake and he's fully lucid and his abdomen remains benign, I think he can be observed. And then if he's observed, I would repeat the CT after 4 to 6 hours if he's doing well, or if he continues to do well, everything's fine, maybe delayed to 12 hours, just as an interval study to be sure that there isn't a perforation that is missed and that's progressing.
Thank you, Doctor. Dr. Nedeljković, your comments?
This is interesting. I would definitely decompress the stomach and the bladder. I would just start empiric antibiotics, resuscitate the patient, but I'm not sure. Who knows? Maybe something happened to him before and he was just walking to the hospital to get a laparotomy for like an abdominal process. I think there is a piece of something that may look like a foreign body on the CT scan, kind of going, down kind of a little distal to the stomach. So I don't think I will necessarily sit on him. I'll definitely get labs, lactic acid right there. And I think I would take him to the operating room. Thank you.
Thank you, Doctor. Dr. Fraga, your comments, please.
Just some question to Dr. Collet. How long the time between the trauma and the CT? About 1 hour, 2 hours?
1 hour, no more.
1 hour. Okay. Do you have the white counts? Do you have leukocytosis?
I go to show.
Okay, because if I had a patient like this one, after this finding in the CT, I agree with someone who told about this, to go back to the patients, ask some question to the patients about if he had pain before walking the street, because maybe he has another disease. And the arterial blood gas is important. If he has acidosis, the lactate can bring some information. Probably you are some complementary exams. Sometimes the amylase, I don't know in English, amylase is a little high when you have a small bowel perforation. I think is an important complementary exam in this situation. And it's very difficult for us surgeon, just look for pneumoperitoneum, don't do nothing. I think the laparoscopy approach is a good option in this case. Thank you.
Thank you, Dr. Fraga. Anyone else, any comment?
I just like to say one thing about laparoscopy in a patient with pneumoperitoneum. Although it sounds easy, when a patient comes in with pneumoperitoneum, you induce pneumoperitoneum to laparoscopy, your cardiac output is going to drop precipitously in an elderly man. So be aware of that.
Thank you, Dr. Kasim.
And
Dr.
if I
Collet?
may add what Dr. Cassin already mentioned, he's too distended also. It would not be room to work in this patient unless you increase the pressure. Behind the stomach, there is something, I think it's a vessel, but it goes very straight. That's probably what everybody is thinking, myself included, that hold on, there. That thing, what is that? Is that the vessel? Is the stomach rotated? I really, to make sure, I really would like to see other views, like a coronal view or a sagittal view. That initially I thought it was the NG2, but obviously it's not. So it looked like it's the left gastric, but it's on the other side of the stomach. I really kind of confused.
This is a vessel, Dr. Hosman. It's a vessel.
I have another thought and comment, if I may.
Sure, go ahead.
It may be possible that, you know, hypertension like this in somebody unexplained and this weird CT scan finding, what if he's carrying something intraluminally into his gut across the street? So who knows how this unfolds. I'm looking forward to it.
70-year-old mule, yeah.
Dr. Collet, we go back to you.
Okay, I agree with all comments. It's very important because you can see something important. Some patients don't know what happened with his body. Some patients just live and there's hypertension, there is sometimes they adjust the dietary with the conditions of the stomach, and then they come to us very late in the disease perform. So this patient here, you can see the hemoglobin is normal, the leukocytosis is normal, platelets is normal. So we decide with this exam laboratory what to do. This patient here, you can see the abdomen of the patient. Okay, it's very, very normal, but you have a very free air in the abdomen and free fluid in the abdomen. So what to do with these patients? Because there is a problem. In these situations here, the people don't believe that something maybe is changed with the CT, so they make another CT around 80 hours after the trauma, and the CT is exactly the same. So what to do in this patient? Can see? Valeria? No operative management, laparoscopy, laparotomy in this patient.
Okay. Dr. Nedelkovic, would you like to make comments?
I would explore if it's possible to just put a scope in, you know, try again and make sure his blood pressure is under control. I'm not sure if he's on a drip or not. If he remains hypertensive, you know, he will need to be on a drip, but I would explore. I don't think it's any harm trying to put a scope in, especially after you decompress the stomach in the distended duodenum. Hopefully you have room to work. If not, convert to laparotomy. I don't think I would be comfortable not intervening and do non-operative management. Thanks.
Thank you, Doctor. Dr. Supa, your comments?
I think the part that I'm worried about in this patient is the duodenal injury, because sometimes you can have a benign abdominal examination with duodenal injury, but anyway you waited like 8 hours and you repeated the CT scan which showed the same finding. I think I would sit tight and maybe choose the non-operative management in this patient. Put the NG tube in, decompress everything, and NPO the patient, and observe him maybe 1 more day and see if anything changes. And the other option, less than laparoscope in this patient. If I'm concerned about a duodenal injury, I may get the water soluble contrast examination of the stomach and the duodenum. And if I could rule out the duodenal perforation, I think I would be happy with wait and see in this patient. Thank you.
Thank you, Dr. Supa. Dr. Fraga, your comments, please.
Yes, a very difficult decision because the exam of the patients is totally normal. No signs of a trauma in the abdomen, but he has a pneumoperitoneum. I think probably he has a perforated peptic ulcer, feels symptomatic at this point, and I think laparoscopy is safer for the patient. But other option is just observe in the hospital. Keep this patient for 2-3 days at the hospital and just follow the patient with clinical examination. It's another option. But the patient has no pneumothorax. Sometimes when you have a pneumothorax, you can find a pneumoperitoneum and no pneumothorax in this patient. Probably I do a laparoscopy, a diagnostic laparoscopy to look if there is something wrong in the abdominal cavity. But at the CT, you can observe only the air, no free fluid at the CT. So it's difficult. But if you try just to observe it, I think it's okay. I think everybody in this room will learn with this patient at the end of this session. Use the patients teach to us. So my opinion, laparoscopy. Thank you.
Thank you, Doctor. Dr. Vishakiran, do you have a question? Okay.
Yes, this goes to a long time training. And since you put the NG down, would you put some air down that NG with a bag of air and just inflate and see if just a erect X-ray and you would get more air and then you could decide if it was a perforation? Would anyone do that?
Dr. Hoffman, would you like to make any comment?
No, I wouldn't do that. I remember we were doing that many years ago, but we don't do that anymore, looking for free air, because we have the CAT scan, which is much more sensitive. That was when we were doing plain films. I would probably do if I have a reliable physical exam, I would do non-operative management. If he has any type of bowel injury, in 2 hours, he will be asking to have the surgery himself because of the pain. But he has no pain, I would probably observe and see what happened. Maybe repeat the CT scan in a few hours, but I would not operate at this time.
Thank you, Dr. Hoffman. Dr. Untrak, your comments?
Yeah, so if I understand correctly, it's been 8 hours. The CAT scan has not changed. The labs are benign and unchanged. So, and the patient remains awake and the abdomen's benign. So I think I would be inclined not to put him under general anesthesia, even for a laparoscopy, but I would put gastrografin down the nasogastric tube once the stomach is decompressed, and be sure to pacify the duodenum down beyond the ligament of Treitz, and then that would rule in or rule out perforated ulcer. And even if he did perforate an ulcer, some of them seal off, and not all of them need to be operated upon. You know, if it just is formed a pseudodiverticulum, you can keep the stomach drained and put the patient on proton pump inhibitors, and often they'll just continue to close up. But I would look for an obvious source of perforation with contrast material. Otherwise, I would continue to observe him. In addition, on the video that you showed, Dr. Collet, it looks like he had a lower midline laparotomy. Was that a scar there in his lower abdomen, or it just it looked like there? It could have just been a unclear video, but it looked like he may have had surgery before in the abdomen.
Dr. Collet, Dr. Antrak, that was a question for Dr. Collet, correct?
Yes, yes, right.
The patient has no scare in the abdomen. The abdomen is
Okay.
flat. Okay, that's it.
Okay. And Dr. Kasim, your comments, please.
I have two thoughts on this. To go back to Dr. Supra's duodenal injury, most duodenal injuries in blunt trauma, they occur as a retroperitoneal injury. So quite often you will see air around the right kidney, and also you will see air around that area. And so not seeing that, so I doubt very much this is an occult duodenal injury. I still like to bet my $2 on pathology in the colon. So what I would probably do if I am getting all excited about this case, so far I haven't been excited, and I would do what is called a triple contrast study. Give him a contrast orally, and give him a contrast rectally and an IV. And that's the CT that I would have done in the second time around. That might help me a little bit more information of the GI tract to see if there is any perforation. Again, I follow the teachings of Dr. Zachary Cope, who has a wonderful book on physical examination of a sick patient. If the patient exhibits benign abdominal condition, unless there is an extenuating circumstances that you need to operate on the patient, by all means you should have operated on a few hours before. But in a patient like this who does not show any signs of peritoneal sign, all we see is air under the diaphragm, and the reason for that is not quite determined until the reason elucidates itself. I would just sit tight. I would think I would keep watching him to see what happens. I'm hoping nothing will happen to him. Thank you.
Thank you, Dr. Antrak. Dr. Collet, we go back to you.
Okay. So in this patient, I decide to make a laparoscopy in this patient. I put this patient in the OR and make a laparoscopy. So you can see here, you can see some bubbles. Here.
Ay, justo estoy.
And see free fluid in the abdomen, the liver. There's no injuries. You can see here, you can try to see the stomach. The stomach is too big, too much big. It's very difficult to see. Here you can see the stomach. You can see free fluid in the subphrenic, left subphrenic space. The liquid was aspirated. And you try to find what's happened. You can see here, near the liver and the biliary, you can see here some fibrina near the duodenum. Only fibrin here. And so at this moment, during the surgery, no other injuries. Here you can see the stomach, the liver, the left liver. And you can see fibrin here. You can see some fibrin. And no more finding in the laparoscopy. At this moment, what I think to do in this patient are here, I try to it's very difficult to mobilize this big stomach in the abdominal cavity with the laparoscopy. So what to do with these patients now? You can stop the procedure, continue the procedure, you can convert the procedure, you can make another exam in these patients at this moment during the surgery. Someone can suggest?
Dr. Kasim, your comments?
Well, now that you have determined the patient has bile stain fluid in the abdominal cavity, and there is some fibrin and inflammatory process going on, and you're not really happy with what you have seen, other than you are seeing something, and that needs to be attended to. Most likely it is a perforation, and like Dr. Untrak mentioned earlier on, sometimes when you have a patient, sometimes you do see a patient who has perforated duodenal ulcer and it seals itself. And that's the thesis behind a famous English surgeon who used to treat perforated duodenal ulcer conservatively. I think his name was Professor Harold Ellis. He was from Westminster Hospital in London, England. And so this may be a case where the perforation occurred at the same time that he was involved in an accident, and it sealed itself, and we are not seeing the hole in the entry wall of the duodenum, and he may have had a silent duodenal ulcer that perforated at the same time he had an accident. So I would feel very uncomfortable because I don't like to leave things kind of half done. And now that I have determined the patient has bile-containing fluid, I think I would get very curious to see, am I missing something here? I think I would convert this into a laparotomy and have a good look at it to make sure that I have not missed anything, so that the lawyers will be after me. Thank you.
Thank you, Dr. Kasim. Dr. Fraga?
It's very suggestive of duodenal perforate ulcer, this aspect of the fluid in the cavity. So I think it's necessary the definitive treatment. If you have experience to do this by laparoscopy, go ahead. Try to explore the duodenal, try to find the ulcer. If not, laparotomy, open the cavity and do the definitive treatment for the patient. If you don't find nothing, good for the patient, it's better for him. But you cannot stop the surgical treatment and just observe. I think it's a little dangerous for the patient if you don't have the final decision at this moment. Thank you.
Thank you, Dr. Fraga. Dr. Supa, your comments?
I agree with converting the patient to a laparotomy and examine everything thoroughly in the abdomen. Thank you.
Thank you, Dr. Supa. Dr. Ochman?
I've been 24 hours on call, so my judgment is clouded. So with having said that, I'm not sure that the fluid is bilious. It looked to me like clear fluid. The laparoscopy always gives this image of the fluid that appears to be green, but when we get the fluid out, it's just yellow. So that may be clear fluid. Granted, there is some fibrin, but I don't see anything else. That's the reason I would not have done anything with this patient if he has a reliable physical exam, because my concern was that doing laparoscopy, we would not be able to see anything because the stomach was too distended and it was very difficult to mobilize and find a small perforation, which obviously, if he has something, is a very small perforation, because there is just only a very small amount of free air. So I would have continued to watch. If you do this, you are committed yourself of having to do something else. the laparoscopy didn't give you a diagnosis, you would have to do a laparotomy. And maybe, as Dr. Untrach already mentioned, this could be something that already seal on its own. That's a very well described process for peptic ulcer disease, that the patient seals the ulcer on their own with NG tube suction. There were studies even comparing doing conservative management with NG tube suction versus surgery. And surprisingly, the results were very similar, except that the patients who were treated conservatively tended to have a little bit more complications and a longer length of stay. That's the reason that operative treatment continues to be the gold standard. But I have received many patients with even more free air than this, that by the time that they get to our hospital, the pain is free. Obviously, they seal the ulcer on their own, and we don't do anything. Very rarely we need to do anything on those patients. So again, I wouldn't have done anything on this patient. And if I would have done something, laparoscopy probably would not be the option that I would have chosen, because everything is too distended and it would be very difficult to see. Having said that, for perforated duodenal ulcer, laparoscopy is the way to go. So again, I am post-call and I'm probably talking a lot of nonsense, and I apologize. Thank you.
Thank you, Dr. Antrach, no problem. Dr. Nedeljkovic?
I agree with all the comments. We don't know what caused it. It is possible that it's a duodenal ulcer that perfed and sealed off, as Dr. Supa was mentioning and others. So either you convert to open to get your answers versus stay laparoscopically, run the small bowel completely, look at the colon. If that's all normal, then I would consider an intraop PGD to take a look, keeping in mind that you may, whatever is sealed off, you may unseal it. And if you still don't get your answers, maybe even convert to open. But I would definitely run the bowel, make sure there's nothing else, and then consider maybe an intraop PGD, or maybe have them insufflate now some air through an NG tube with some saline over the stomach and see if anything is leaking anteriorly, especially in the area of the fibrin. Sometimes the lobe of the liver can seal things off, and you don't really necessarily see any obvious leak initially. That's what I would do. Thanks.
Thank you, Doctor. Dr. Antrach, your comments?
Yes, I agree with Dr. Hochman. I didn't think that fluid looked very bilious. I've operated on lots of perforated duodenal ulcers, especially they're very common in the third world with a high incidence of H. pylori, and it's unequivocal. The bile is, there's just no doubt about it. You suction some of that out, and while you're thinking, I would just send that to the lab and have them check for white cells and vegetable matter and bile, whatever. But you should be able to see the bulb of the duodenum very easily. The liver is, the stomach may be dilated, but not that dilated. You should be able to pull down on the antrum and expose the duodenal bulb and see it right away. And if you do find a perforation, you could repair it laparoscopically. A couple of sutures, put the omentum there, tie it down, and that would be a good thing, because then you had a diagnosis and you wouldn't have to do a full exploration. Just patch the ulcer the way you would do with a laparotomy and then be done. But and then I agree with Dr. Alex to get a good look, in the pelvis and run the bowel, but look at the duodenum to look for the ulcer, I would have put gastrografin down the nasogastric tube and run it through, do a couple of plain films, and you'd know right away. And that would be an easy way just to rule that out. But now that you're there, I think you can just look directly to find it. And if it's normal, then the issue is, what do you do at that point? And if the fluid really is benign, it doesn't have a lot of white cells, there's no bile in it, the way you would do in evaluating peritoneal lavage fluid, then I would simply I would simply observe him. If there's you didn't have a lot of fibrin below, and there wasn't evidence of some bad inflammation, the omentum looks rather normal. It's not thickened and matted down to some area of pathology. So, I would probably back out and continue to observe him, assuming that you didn't find a perforated duodenum laparoscopically.
Thank you, Doctor. Dr. Collet, we go back to you.
Okay, I agree with all comments. Dr. Husman, your comment is very clear and you're very high. So I start in this patient. I make endoscopy here during the surgery. You can see a ulcer, a stenotic ulcer. You cannot progress the endoscope through the duodenum. It's very, very, very difficult to the exam to progression to the duodenum. This is can see here, can see the ulcer here. And so at this moment, I convert to the laparotomy. So I go to show you, can see here the stomach, here you can see the stenotic, and probably during the trauma, the patients make a microperforations of the ulcer, and maybe some air comes from the duodenum through the abdominal cavity. So you can see here the stomach is very big stomach, very, very big. Stenotic stomach, stenotic enlarged stomach, very, very big. It's a chronic ulcer peptic disease with a stenotic duodenum. Here you can see. Here you can see the inflammatory process. It's very difficult to do to find this process, this extrusion with the laparoscopy. So in these patients, I treat with a gastrectomy. Here you can see the peptic ulcer here. And the patients maybe very well with this surgery. So I want to, I go to show can go to see what's happened in this patient. These patients have start to eat on the second or third post-operative day and discharge on the seventh post-operative day. As you can see, this patient, the great problem, they have problem is hypertension, arterial hypertension, and they have probably a peptic ulcer. It's a chronic disease, long time. And when I ask in the post-operative with the patients that cannot eat or usually can be vomiting periodically, and they are lose weight. So the patients go on the seventh post-operative eating and go to home. So for final comments, Valeria.
Thank you, Dr. Collet. Dr. Kasim, your final comment?
Like I said, he doesn't want to let the cat out of the bag. There's something going on here, and it's a clinical judgment that calls Dr. Collet, who is a master endoscopist, laparoscopic surgeon, converts it to open surgery to find a type 1 duodenal ulcer. And the correct operation for that is a gastrectomy with a Billroth 1 anastomosis. Well done, doctor.
Thank you, Dr. Kasim. Dr. Antrak, your comments, please.
Well, very, very interesting case that explains a lot. So I take it you did not find an obvious perforation of the duodenum. Is that right, Dr. Collet?
Yes, I don't find obvious perforation. It's very small perforation, probably.
Okay, and you did a Billroth 1 reconstruction?
I make a Billroth 2 because of the gastro.
Yes.
Come on.
Yeah, because it looks like you did a subtotal gastrectomy. So yeah, and perfectly fine to do that, and the patient did well. And and these days with the proton pump inhibitors, we no longer do vagotomies if we have a perforated ulcer, and a lot of them are due to the ulcers due to H. pylori. So, you know, the surgical management has changed. That's perfectly fine the way you did that. And the other option in an elderly man who just had an accident would have been a gastrojejunostomy, which is basically would be the same, you know, the same thing, except without removing the stomach, and then keep him on H2 blockers. And, you know, the duodenum possibly could open up, in which case a gastroenterostomy would close, but it's perfectly fine the way you did it. But there you go. So it's more of a chronic manifestation rather than an injury from acute trauma. Interesting case. Well managed.
Thank you, Dr. Antrak. Dr. Nedeljkovic.
Is the ulcer benign? Do we have the path report? Where I was going with this is, you know, probably resection is better. You don't know if it's a cancer or not. And great case, nice presentation, and thank you for presenting it.
Thank you, Doctor. Dr. Rochman.
No, I have really nothing to add. Dr. Collet, as always, has these super interesting cases, and he always managed to solve the puzzle that we all stumble upon. So congratulations, Dr. Collet, great case. Thank you very much.
Thank you, Doctor. Dr. Supa.
Thank you very much, Dr. Collet, for presenting this case. And I think this is a good example for difficult question in trauma situation that you always solve perfectly. Thank you.
Thank you, Dr. Supa. Dr. Fraga.
Congratulations, very unusual case. I have never seen something like this case, but Dr. Collet took the best decision, because it's very difficult for a surgeon just to observe a pneumoperitoneum. Congratulations, very well done. And I think the decision to laparoscopy was the best option. Thank you.
Thank you, Dr. Fraga. Thank you, everyone, for joining.